Since you mentioned heterogeneity, I just want to, because we haven't talked about it at all yet, is, you know, at Mayo Clinic we've sort of long been preaching that people should do genetic testing and risk stratify their treatment in the newly diagnosed setting. Rafael, is that still the case with these?
I think it matters a lot. It matters a lot for two reasons, and not in any way self-serving. First of all, when you counsel a patient who has high-risk myeloma, it's not a person you're going to approach with this notion of, well, we're so fortunate. You know, it's a very concerning disease in the shorter term than the person who doesn't have high-risk markers. Number two, perhaps the most important one, is what you do with transplant and post-transplant is quite different if you have high-risk disease or not. There's pretty good data now that for the high-risk patients, you cannot let go. You cannot use a simple maintenance strategy of lenalidomide-based regimens. I think there's data from several European groups, again, that show that the addition of a proteasome inhibitor is of benefit. And arguably, there's emerging data that perhaps the old question of the tandem transplant should be revisited for high-risk patients, which actually, it is true, but the data is there in front of us, and we can't ignore it.
Is tandem transplant important in Europe because they don't have access to drugs we have here in the United States? Is it so important here, or is it just, however you get into CR is the important thing?
I think getting into CR, cytoreduction, intensity of treatment, and duration of treatment are proving to be important aspects.
I mean, all these studies in Europe use pretty it's lame therapy by U.S. standards, right?
Well, we will have a study that may read out at ASH. I don't know that, but it's the current CTN trial, not current trial, but the trial that's fully accrued that looks at the question of single transplant, double transplant, or single transplant followed by 4 cycles of VRD consolidation. That trial is fully accrued as of a couple of years ago, and the readout from that might occur as early as this fall, in which case we'll have a U.S. answer, if you will, to the question of 1 versus 2.
Yeah, I suspect what matters is the complete remission, not so much how you get there.
Keith, if I may, one of the things you mentioned with your treatment, so you want to put all your treatments as sort of packages in the lines of treatment for patients, and if you do transplant upfront versus later, there's quite a bit of a difference in the durability of the response. So if you treat it like a financial asset, a capital expense, transplant up front, you depreciate over many more years than if you do transplant down the line, right?
You're confusing me now.
So that is important because
like a banker.
But it's true because the post-transplant benefit is greater when you do it up front than when you do it down the line for the same investment in toxicity, time out of work, et cetera, if you do it up front.
All right, Jatin, maintenance or no maintenance therapy?
I think maintenance is absolutely the standard of care.
What did you think of this meta-analysis that was presented yesterday, looking at lenalidomide across 3 big, large randomized trials? What was the conclusion of that, and what does that mean for us, or did we already know the answer?
Yeah. So I think we already knew the answer that, at least from the 2 randomized phase C studies of maintenance therapy after transplant, both the U.S. and the French showed progression-free survival, and in the U.S. with progression-free survival benefit or improvement. And in the U.S., with indefinite therapy, we see an overall survival benefit. I think what the meta-analysis really helped is there's still that question for patients who are on therapy for 2, 3, 4, 5 years, and do I need to come off? But now seeing this meta-analysis and overall survival benefit really kind of, I think, continues to.
And there's quite a large overall survival benefit, like over
2.5
years if for people taking lenalidomide. Is that the final word on this, do you think, Bill? Are we lenalidomide's maintenance here to stay for everybody?
Well, I think for the time being, we have the most robust data with lenalidomide, but we also could see emerging data with ixazomib, the oral proteasome inhibitor, which from a convenience standpoint is going to be the same as giving lenalidomide. The other issue to keep in mind is there is a cost for this, not just a monetary cost. You do see a definite increase in second primary malignancies, mainly hematologic malignancies, as a result of lenalidomide maintenance.
So if you use it, how long do you use it for?
I don't think we know exactly.
No, you. How long do
are you asking me?
I'm asking you, yeah.
Well, I use it continuously because I'm not convinced that a year versus 2 years makes a difference in terms of the risk of second primary malignancies. The other thing that I do...
What does continuously mean? Does that mean you stay on for 7 years if you're in remission? Or does it mean 2 years? What does it mean?
I keep them on it as long as they can tolerate it and afford it.
Do you worry about the MDS or MCV type?
One thing I've done recently based on some very early data is to use intermittent lenalidomide. So the 21 out of 28 days, there is some early data that maybe giving it intermittently as opposed to continuously may reduce that risk. But I'd like to see more data on
All
that.
right, let me just I just need snapshots here. How long do you use lenalidomide maintenance for?
So I use lenalidomide maintenance indefinitely while they're benefiting from therapy.
Is that true for both of you as well?
Same, as long as the patient tolerates and the disease is under control.
All right, who do we use proteasome inhibitor maintenance in, and if so, why, Ola?
I think there are occasional patients that don't tolerate lenalidomide, and if they're a high-risk disease, I would consider doing a combination of proteasome inhibitor.
Is that your
and
standard practice to use a combination? And what do you use, bortezomib or?
Well, we have up till now used bortezomib with lenalidomide, but I think
every 2 weeks, or how do you give it?
so. We have given Velcade or bortezomib every 2 weeks as a
Subcutaneous.
maintenance. If you do that as a single drug, I would do it every 2 weeks. If you have high risk, you have different types of hybrids, but probably every 2 weeks.